And when you go online and you talk to the people that may have persistent syndrome or persistent adverse events from finasteride, even though that was months, years ago, I rarely find blood work. I would say that it's important for us when we have someone who's concerned over the potential side effect profile to get them to do the right test. Give them reassurance. So when I have someone that comes to me and so I'm doing the intake calls and someone asks me about hair loss, I say, well, you can probably do what we call a pre-finasteride kind of test where you just look at all the hormones, and from there, although it's no guarantee, there's no obviously scientific method that just makes someone side effect proof to finasteride. But if you see testosterone, nice and high, and there's no imbalance anywhere, there's no vitamin deficiency, there's none of that. Prolactin is good. Prolactin correlates inversely with dopamine. So when you have high prolactin, you have potentially low dopamine, and vice versa. If you have prolactin in check, your dopamine levels are probably good. And DHT may be important for dopamine, right? So you piece everything together, and it's like, all right, you probably will do great on a low dose of finasteride. We can use 1 milligram, which is a low dose every day. Proscar is 5 milligrams, pretty aggressive dose for prostate cancer. But we do have people that may be a little scared and they start slower. They start with 1 milligram twice a week or 0.5 milligrams every other day. Like pretty much I've seen it all at this point. And it comes down to the patient trusting the doctor. So this is pretty big. You need to have psychologists spend some time with the patient, explain why there are side effects and what kind of context you can see. So if someone has low testosterone and then you give them finasteride, then they have low testosterone, low DHT, they don't have any signaling to the androgen receptor. So you may expect side effects from that. Actually, low estrogen is also important. You know that low libido usually is low estrogen in pretty much all animals, including humans. So yeah, low estrogen, not the best for libido. And if you have low testosterone in men, then there's a pretty decent risk that you have low estrogen. And when you go online and you talk to the people that may have persistent syndrome or persistent adverse events from finasteride, even though that was months, years ago, I rarely find blood work. Like that's not a thing. So maybe it's a matter of having access to blood work. Maybe it's a matter of cost because DHT is expensive. I know that I live in Canada. If I want to get DHT tested, it goes to the United States and then comes back. So it's just it's a whole thing, And I've seen other people online with DHT testing, and it goes to the United States. Mm-hmm. So it's not easy. And then you go and you ask your primary care provider to test for DHT. I don't know how often that actually happens. And even just doctors that are more capable in the testosterone optimization field. Everybody tests for testosterone and estrogen, but not so much DHT. So. Yeah, this is data that we don't really have. And when you have that data, you can actually give reassurance to your patient where they think they have post-finasteride, and then they will see testosterone is looking good, DHT is looking good, estrogen is looking good. Now we can go very advanced and look at neurotransmitters, urine testing for neurotransmitters. We see that, and if you investigate, and you may find something, and then you can just address it. And that is building a lot of trust in your provider. And if you find something and you address it and then symptoms go away, now that's a success story.
Yeah, and I think if you're looking at it like the pre-finasteride screening, right? So making sure all your hormones are in check before you introduce another variable that's definitely going to skew different hormone levels. You go out the list, yep, prolactin's good, estradiol good, testosterone's good, yep, your DHT is in the not hair loss safe zone, so we need to lower that to some degree, and how much we need to lower it and what dose. And you go through and you put the patient on an individualized plan. You start the dose low, work your way up, and then they would tend to have a much better outcome than if I just took somebody out of the general population and said, hey dude, you're losing your hair, here's 5 milligrams of finasteride. That person is much more likely to have sexual dysfunction than the person who goes through this process is working on getting their health in check and all these sorts of things before they introduce that variable. I think that's really beneficial.